Hi guys, welcome back to week 8. I just wanted to do a quick review and summary of just some major key points I wanted to refocus on. I know that the professor has already prepared PowerPoints for you guys that are great, and I don't want to take away from them, but there are just a few things I just want to make sure we review, and hopefully this will also be helpful in preparing for your next exam. So let's get started. This week, we're just talking about circulation, cardiac, and heart. Obviously, there's a lot of EKG stuff involved, just making sure you're doing a review of just the basic anatomy of the heart, structure, function, circulation, that kind of thing. In terms of just basics, let's definitely make sure you've reviewed the structural organization of the heart, the blood flow. I want to make sure we're keying in on pulmonary circulation versus systemic circulation. Down here in the bottom left corner, I just wanted to point out one of the ways that I studied cardiac circulation and just reviewed where murmurs were within the heart and where they occurred. I went onto Google and printed this, down here in the left corner. I printed like a blank printable form of the heart. And there's tons of them for free. You can just print and then you can fill in yourself. And I colored it in myself. I wrote the labels myself, and I wrote definitions of and just pointed to where murmurs were on this particular worksheet that I myself just really spent some time on because it really helped just give me a really clear visual foundational guide to all of these things, cardiac circulation in total, as well as where murmurs are located and where they would occur. So I just wanted to share that tidbit and just how to study for this particular thing. And again, I can't stress enough in terms of murmurs, make sure you remember like the definition of the murmur, as well as recognizing, on hearing it, if you can recognize it. So those YouTube videos with cardiac murmurs are so helpful. If you find one that really works for you, listen to it a bunch of times just to make sure that you're really grasping it, right? Okay, so next, I just wanted to make sure you're really on top of reviewing atherosclerosis. This is really, really important in terms of understanding how it develops and how we treat it, and the importance of treating it, as well as educating your patients in practice on, how to prevent this from getting to the point of this severity, where we end up, developing plaque and plaque ruptures and blood clots form. So it's all about talking about, lifestyle changes and good dietary intake and, good nutritional choices, as well as just making sure you're reviewing that history in your patient's genetic history, family history. Do we have a history of this? Do we have a history of heart disease? Do we have a history of sudden cardiac events in the family, of sudden cardiac death? Like, we need to know about this. We need to talk about it because, again, these things put your patient at higher risk. So just remember that. Okay. Next, I really wanted to just make sure, obviously you're reviewing hypertension and how it all connects with the kidneys. I wanted to make sure that you just really reviewed the role of ACE inhibitors in hypertension, and the just to make sure like you understand the concept of the angiotensin II levels in the blood, what it does, how it causes decrease in vasoconstriction, and a drop in aldosterone, change in your fluid volume, and then of course a drop in the blood pressure. Next, diabetes. So I just wanted to make sure we have a really clear understanding of the severity of how peripheral artery disease and diabetes interact. Keep in mind, 1 in 3 people with diabetes over the age of 50 is likely to have peripheral artery disease. And keep in mind, smoking also increases the risk of peripheral artery disease in some studies by 400%. Obviously, other risk factors that are contributory to this is high cholesterol, high blood pressure, and coronary artery disease. Next, I wanted to make sure everybody has reviewed the different types of shock and the clinical manifestations that are associated with each different type. Okay, we have anaphylaxis, cardiogenic, hypovolemic, obstructive, neurogenic, and of course, one of the most commonly talked about, especially now, is septic shock. Okay, so just make sure you review those signs and symptoms, the causes, and then of course, how we would treat. Next, I wanted to make sure we review and just are very conscientious about being able to describe the clinical presentation of venous insufficiency. Here are some stages of chronic venous insufficiency in terms of spider veins. So here we have on the left normal veins, then we develop spider veins as time goes on. Then we develop varicose veins. As you can see, they're protruding. This is a very genetic type thing too. So it tends to transfer on in women and families. So then, of course, as time goes on and these veins continue to become much less sufficient, we'd get swelling and skin changes. And then later on, we start to develop our venous ulcers. So here, when it comes to venous insufficiency, start educating your patients, lots of rest periods, elevation, use of TED stockings, limiting their walking or standing, just start educating your patients on how to prevent things from getting worse. Next, angina versus myocardial infarction. So it's really important that you are able to differentiate the different types of angina, as well being able to differentiate angina from an actual MI. So just keep that in mind. You want to know the symptoms of angina and the symptoms of MI, as well as the treatments. Okay, next big topic that I want to make sure that you guys have reviewed and are very well aware of, not only for your next exam, but for your boards, as well as obviously your clinical practice, but this is a big one on the boards. So you want to make sure on an EKG rhythm strip, as well as being able to define the differences between a STEMI versus a non-STEMI. Okay, you want to be able to differentiate that on EKG, as well as be able to define the differences. Next, cardiac damage. I want to make sure that you are conscientious about the type of labs that would indicate cardiac damage. Also, we want to make sure you're grasping what an ejection fracture is in terms of, how the effect on the reduced ejection fracture on preload. So things that would affect your ejection fracture are definitely factors such as your stroke volume and your cardiac output. So here in this video, actually, let's go back. So in terms of the blood test, the labs, I just want to make sure that we review that for heart disease. So we're looking at your troponins, albumin, BNP, your cholesterol, C-reactive protein, and lipoprotein. These are all the things that you want to make sure you're evaluating for any sort of heart disease, whether it's acute or chronic. You want to make sure that these are always constantly updated. Next, let's just talk about the differences between cardiac output, stroke volume, EDV, ESV, and the ejection fracture. Okay, this is a great, very short video that gives you a great visual of how these all apply.
Cardiac output is the amount of blood pumped by each ventricle in 1 minute. It is the product of stroke volume, the amount of blood pumped in one heartbeat, and heart rate, the number of beats in 1 minute. An increase in either stroke volume or heart rate results in increased cardiac output, and vice versa. For example, during physical exercises, the heart beats faster to put out more blood in response to higher demand of the body. It is noteworthy that the ventricles do not eject all the blood they contain in one beat. In a typical example, a ventricle is filled with about 100 milliliters of blood at the end of its load, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The 100 milliliters is the end diastolic volume, or EDV. The 40 milliliters that remains in the ventricle after contraction is the end systolic volume, or ESV. The stroke volume equals EDV minus ESV and is dependent on three factors: contractility, preload, and afterload. Contractility refers to the force of the contraction of the heart muscle. The more forceful the contraction, the more blood it ejects. Preload is related to the end diastolic volume. Preload, by definition, is the degree of stretch of cardiac myocytes at the end of ventricular filling. But since this parameter is not readily measurable in patients, EDV is used instead. This is because the stretch level of the wall of a ventricle increases as it's filled with more and more blood, just like a balloon. The more air it contains, the more stretched it is. According to the Frank-Starling mechanism, the greater the stretch, the greater the force of contraction. In the balloon analogy, the more inflated the balloon, the more forceful it releases air when deflated. Afterload, on the other hand, is the resistance that the ventricle must overcome to eject blood. Afterload includes two major components: vascular pressure. The pressure in the left ventricle must be greater than the systemic pressure for the aortic valve to open. Similarly, the pressure in the right ventricle must exceed pulmonary pressure to open the pulmonary valve. In hypertension, for example, higher vascular pressures make it more difficult for the valves to open, resulting in a reduced amount of ejected blood. Damage to the valves, such as stenosis, also presents higher resistance and leads to lower blood output.
All right, hopefully that was helpful in terms of a review. And that's it, guys. So those are the main points I just wanted to make sure that you really focused in on in the following material with the other voiced over PowerPoints, as well as in your readings. Thanks and have a great week.